my name is Amber Goana and I would like to welcome you to my Med Talk. This is going to be some of the things I pulled from the CPJE California law exam, and as you can see, it's going to be basically like a little Naplex, and so each video is just going to go over each section that I kind of pulled little things from, and I hope you like it. So for this Med Talk, we're going over medications that have an FDA-approved use in depression. First up here we have selective serotonin reuptake inhibitors, also known as SSRIs. These work by selectively blocking the reuptake of 5-HT serotonin at the neuronal membrane, and it's going to increase the action's levels of serotonin. An example is fluoxetine, Prozac. That's dosed at 10 to 60 milligrams a day with a max of 80 milligrams a day. It actually has a very long half-life, fluoxetine. Next we have paroxetine Paxil. It's 10 to 40 milligrams a day with a max of 50 milligrams a day. You want to avoid use in pregnancy. You want to take paroxetine at bedtime, and it actually has a quite short half-life. It is FDA approved for all anxiety disorders. Paroxetine is. We have citalopram, Celexa. It's 20 to 40 milligrams a day with a max of 40 milligrams a day. But if you're using it in the elderly, the max is going to be 20 milligrams a day for citalopram. We have escitalopram, Lexapro, which is dosed 10 to 20 milligrams a day with a max of 20 milligrams a day, but if you're using it in the elderly, you want to have that and do 10 milligrams a day. Sertraline Zoloft, it's dosed 50 to 200 milligrams a day, and it's a good choice for patients with cardiac risk. Fluvoxamine Luvox, 50 to 300 milligrams a day. You want to take this at bedtime, so just like paroxetine, take it at bedtime. It has a short half-life, just like paroxetine. It has a short half-life. Vilazodone is an SSRI, but also a partial agonist of 5-HT. Viibryd is another name for it. It's dosed 10 to 20 milligrams a day with a max of 40 milligrams a day. You want to make sure you take this Viibryd with food, and it is known to cause seizures, but it actually has less sexual dysfunction side effects. Viroxetine is an SSRI as well as an agonist, also an antagonist of 5-HT. Trintellix is another name. It's 5 to 20 milligrams a day, and it's known to cause seizures but less sexual side effects, just like the Viibryd. General precautions in these SSRIs: they do have an increased risk of suicidal thoughts in younger patients in the first several months. You want to avoid use with MAOIs. You want to wait at least 2 weeks, most of them, but actually 5 weeks for fluoxetine because it has that really long half-life. You also want to avoid linezolid, IV methylene blue. Some side effects include QT prolongation, GI effects, increased bleeding risk, dry mouth, diaphoresis, some sweating, tremor, increased risk of fall, and sexual dysfunction. The next set of options we have here is serotonin and norepinephrine reuptake inhibitors, also known as SNRIs. They inhibit the reuptake of serotonin and norepinephrine, and these are also actually used for neuropathic pain. There's venlafaxine Effexor. It's 25 to 150 milligrams a day with a max of 375 milligrams a day. It's known to cause elevated blood pressure in doses greater than 150 milligrams a day. It can also cause QT prolongation. It will only need a 7-day washout period whenever you're trying to switch to like another medication, especially like an MAOI. You want to wait just like 7 days only. It is a 2D6 inhibitor. Desvenlafaxine Pristiq is 50 milligrams a day. You got duloxetine Cymbalta, 40 to 60 milligrams a day with a max of 120 milligrams a day. You want to avoid use in creatinine clearance, less than 30 milliliters per minute, and it is a 2D6 inhibitor just like venlafaxine. And last up here we have levomenacepram, Vabysmo. It's 20 to 120 milligrams a day, and it also only needs a 7-day washout period, just like the Effexor. General precautions for SNRIs: they increase risk of suicidal thoughts in younger patients in the first several months of use. They're going to need that 2-week washout period before you're going to start an MAOI, unless you know it's the Vabysmo or the Effexor that only needs the 7 days. You also want to avoid with linezolid and IV methylene blue. Some side effects include all the ones like the SSRIs, but also an increase in heart rate and blood pressure. It could dilate your pupils, cause excessive sweating, as well as constipation. The next set of options here is a tricyclic antidepressant, TCA. It inhibits the reuptake of serotonin and norepinephrine. It also blocks histamine, acetylcholine muscarinic, as well as alpha-1 adrenergic receptors. Nortriptyline Pamelor. It's dosed 25 milligrams 3 to 4 times a day. It's actually a secondary amine. Despermine, norpirmine, is 100 to 200 milligrams a day with a max of 300 milligrams a day. It's also a secondary amine. Then we have amitriptyline Elavil. It's 100 to 300 milligrams a day, taken at bedtime. This is a tertiary amine. It's known to cause myocardial infarction. We have doxepin. It's dosed 100 to 300 milligrams a day. It's a tertiary amine. It's known to cause angle closure glaucoma, as well as urinary retention, PSA levels. We have chloripirine, Arnavil. It's used mainly for OCD, and it is a tertiary amine. Imipramine, toripranil, it's 50 to 150 milligrams a day with a max of 300 milligrams a day. It's also a tertiary amine. Trimipirine, suretamil, it's 75 to 150 milligrams a day with a max of 200 milligrams a day, and it's also a tertiary amine. The tertiary amines have more side effects than secondary. Increased risk of suicidal thoughts in children are seen in the first 2 weeks of use. You want to avoid use, wait at least 2 weeks, for an MAOI. You also want to avoid linezolid and IV methylene blue. The side effects are very, very similar to SS and SNRIs. It can also cause orthostasis, which is lowering your blood pressure, sedation, lethargy, confusion, weight gain, vivid dreams, and lower your seizure threshold. Another class of options is the monoamine oxidase inhibitors, MAOIs. They irreversibly inhibit monoamine oxidase, causing an increase in norepinephrine, epinephrine, dopamine, and serotonin, which is going to put the patient at a high risk for a hypertensive crisis and serotonin syndrome because of that irreversibility. Phenelzine, Nardil is another name for it. It's 15 milligrams 3 times a day with a max of 90 milligrams a day. It is known to cause sedation, so you might want to take this kind of later in the day. There's isocarboxide, Marplan, 10 milligrams twice a day with a max of 60 milligrams a day. It also causes sedation. Tricyclopramide, Parnate. It's 30 milligrams a day with a max of 60 milligrams a day. It's known to cause insomnia, so you might want to take this earlier in the morning. So the Marplan and the Nardil may be closer to the end of the day, but it is technically dosed multiple times a day, so just be aware it can make you a little sleepy. And the Parnate is more for morning. Seglin, MSAM, it's 6 milligrams a day with a max of 12 milligrams a day. You want to avoid use in serotonergic drugs that are known to cause gas and loss of appetite. So you could lose some weight if you take some MSAM. General precautions with all these MAOIs: you do not cut these patch formulation, and you want to make sure you change the patches every day. It definitely increases your risk of suicidal thoughts in younger patients within the first few months of use. It needs to be tapered off to avoid cholinergic rebound. Eating tyramine-rich foods, examples are pickles, aged cheese, soy sauce, yeast extract, dry summer sausage, and fava beans, because of that increase of hypertensive crisis and serotonin syndrome. The side effects we're looking at here is dry mouth, blurred vision, urinary retention, constipation, orthostasis, so maybe some low blood pressure when you're standing up, weight gain, and sexual dysfunction, but maybe even weight loss with the MSAM. We have atypical antidepressants. Example is bupropion, Wellbutrin. It works by inhibiting the reuptake of dopamine and norepinephrine. It's dosed 300 to 450 milligrams a day. It has no additive risk if you take it with an MAOI. So it is okay to take bupropion with one of those MAOIs. It's known to cause dry mouth, weight loss, insomnia because it has CNS stimulation, so you might want to take it earlier in the morning, and seizures at higher doses. We have Contrave, which consists of bupropion and naltrexone. It is specifically for weight loss, though. It's FDA approved specifically for weight loss, not really depression, but I just wanted to include it here. You got trazodone, Deseril. It's 150 milligrams to 375 milligrams daily at bedtime. Known to cause orthostasis, so your blood pressure could be a little off. Risk of perispasm. Seek medical attention if your erection lasts than 4 hours or more. It can also cause sedation. That's why it's usually taken at bedtime. Trazodone works by inhibiting reuptake of serotonin and also blocks histamine and alpha-1 adrenergic receptors. Nefazidone, Surzone is the brand name for it. It works by inhibiting reuptake of dopamine and norepinephrine, kind of like trazodone, but it also blocks alpha-1 adrenergic and HT2/5 serotonin receptors. The dose is 100 to 200 milligrams twice a day. It's known to cause hepatic disorders, but less sedation effects. It also has that risk of perispasm, so if your erection lasts longer than 4 hours, you might want to seek some medical help. And also orthostasis, so it's pretty similar to trazodone. We have mirtazapine, Remeron. It's going to work by inhibiting alpha-2 adrenergic receptors in the presynaptic neurons, which is going to cause an increased release of norepinephrine and serotonin. It's dosed 15 to 45 milligrams at bedtime. It definitely is going to cause sedation. It's also known to cause weight gain and an increase in appetite. So some patients who are elderly and they're having a hard time getting them to eat, they might actually put them on Remeron specifically for that. It can also cause QT prolongation, constipation. General precautions with all these atypical antidepressants increases the risk of suicidal thoughts in patients who are younger within the first several months of use. You want to avoid use, wait at least 2 weeks after you stop the medication for an MAOI. Linezolid is something you also want to avoid, as well as IV methylene blue. There are a few antipsychotics that are approved for depression. They are in the second generation. They work by partially antagonizing the dopamine and serotonin 5-HT2A receptors. It's Seroquel. Quetiapine is another name for it, the generic. It's 50 to 300 milligrams daily at bedtime. It causes sedation and extrapyramidal side effects, where you have kind of stiff, jerky movements, or the Parkinson's-like movement, or you're just not really able to move like the way that you're trying to get your body to move. There's aripiprazole, Abilify. It has the antagonist for the 5-HT2A and then an agonist for the 5-HT1A. It's dosed 2 to 15 milligrams daily at bedtime. Known to cause compulsive disorders, impaired impulse control, so maybe like gambling or shopping, or some people who do like binge eating or like sexual urges. It can potentially cause that. It also causes insomnia, so that's why you want to take this in the morning, aripiprazole. It is the least likely to cause dyslipidemia, so it's not going to really mess with your cholesterol levels. Then we have Symbyax. It's a mixture of olanzapine and fluoxetine. The second generation antipsychotic mixed in with an SSRI. The usual dose is 6-25 milligrams daily at bedtime. It also can cause QT prolongation as well as that sedation while you take it at bedtime. That QT prolongation mainly comes from the olanzapine component. Then we have Brixapirol, Rexulti. It also is an agonist for the 5-HT1A, so it's pretty similar to that Symbyax, where it has that agonist and antagonist effect. It's dosed 0.5 to 3 milligrams, and it is the least likely to see any type of side effect. But side effects you may see in general from the second generation antipsychotics: weight gain, increased blood sugars, dyslipidemia, orthostasis, or just increase your fall risk, leukopenia, neutropenia, and tardive dyskinesia, like your jerky movements. Last up here we have a class that inhibits N-methyl D aspartate receptors. The mechanism is not completely known, but it is non-competitive antagonists for this receptor. They are class 3 drugs, so they are controlled, and they are going to require a REMS program, so the patient and the pharmacy need to be signed up with that. The only option here is esketamine, Spravato. This is actually administered into your nose, and it has to be under supervision of a healthcare provider. General precaution: it should only be used as adjunctive therapy whenever they're having an inadequate response to 2 or more depressants at adequate doses. So that's not something that you're just going to be on singly. You know, you're having trouble with your depression and they want to add something on, this could be an option for you. It has a warning for abuse, misuse, and suicidal thoughts, behaviors. You want to avoid use in intracranial hemorrhage, or if your patient has like blood vessels that are kind of losing their walls, it's ballooning out, or if your patient's pregnant. Clearly, if they have a hypersensitivity to esketamine or ketamine, you don't want to be giving them this. Side effects include increased blood pressure. It can cause you to be sedative, cognitive impairment, and vertigo, as well as actually anxiety. So you're trying to treat depression, it can cause them to have anxiety. Some of these medications cause things that people don't really, want to experience. So if your patient is concerned about sexual dysfunction, your good option is bupropion or mirtazapine, because it doesn't really cause that. You definitely want to avoid most of the SSRIs, especially paroxetine and fluoxetine, because they cause sexual dysfunction. For weight gain, your go-to is going to be bupropion, and you definitely want to avoid paroxetine and mirtazapine because it could definitely cause some weight gain. If your patient is worried about having low energy, your go-to is going to be SNRIs, specifically the duloxetine and venlafaxine, but also bupropion could be a good option for them. You would want to avoid paroxetine and mirtazapine because those are kind of sedating, so they might not have as much energy throughout the day. If they're worried about anxiousness or irritability, a good go-to for them is going to be an SSRI, but you kind of want to avoid the SNRIs and bupropion if you're trying to avoid being anxious. That additive QT prolongation, they all kind of have it, but you definitely, the ones you want to for sure avoid: citalopram, that max a day is going to be 20 milligrams a day, and then escitalopram, you want to max that out at 10 milligrams a day. Venlafaxine, all the TCAs, and mirtazapine also have a pretty high chance of causing QT prolongation. For withdrawal symptoms, It's going to be good to do the patient on fluoxetine because it has a longer half-life. So they're going to have, if they kind of forget to take their medicine, it's not going to be as bad for them. It's still going to have a little bit effect from the day before. You kind of want to avoid paroxetine and venlafaxine though because they do have a shorter half-life. Pregnancy, a good option would be psychotherapy, which is going to be non-pharmacological treatment for them, for mild treatment. You definitely though want to avoid paroxetine for sure. Postpartum, a good option is going to be brexanolone. It's actually the first FDA approved treatment in pregnancy. That medication actually works on the GABA receptors. We didn't really talk about that one. Breastfeeding, your go-to is going to be SSRIs or TCAs, but not really doxepin. You don't really want to take if you're breastfeeding. So that TCA you kind of want to steer away from. A lot of these medications are going to mess with your serotonin levels. So if your patient is having serotonin syndrome, some signs and symptoms you could see is tremors, akathisia. So they're going to be really restless. You can also see involuntary muscle movements as well as hyperthermia, sweating, hypertension, tachycardia, and their pupils are going to be dilated, so pretty large. For a hypertensive crisis, some signs and symptoms is hypertension, hyperthermia, tachycardia, agitation, coma, and even death. So that is all the FDA approved medications they have listed for the treatment of depression. Again, my name is Amber Gowana and I wish you the absolute best of luck in all your studies.